Well, here we are, time for our last presenter of the day, and that is Dr. Jennifer Taylor-Cousar, a tenured professor of adult and pediatric pulmonary medicine at National Jewish Health in Denver, Colorado, where she serves as the medical director of clinical research services, president-elect of the medical staff, and co-director of the adult CF program. Her research focuses on the development and evaluation of novel therapies for treatment of CF and on the unique health needs of women with CF. Her presentation today is titled, Until It's Done for Everyone, Diversity, Inclusion, and Equity in CF Care and Research. Please welcome Dr. Cousar.
Thank you so much to the organizers for the opportunity to speak today, and even more importantly, for the opportunity for this to be on the agenda. These are my disclosures, none of which are directly related to today's presentation. So I wanted to start out and make sure that we're all on the same page. So it's critically important to understand that race is a social construct. So racial categories are social and politically defined categories without a biological basis. Dr. Pabo from the Max Planck Institute actually said that even between Africa and Europe, there's not a single absolute genetic difference, meaning no single variant where all Africans have one variant and all Europeans have another one, even when recent migration is disregarded. Then Dr. Udell from the public health department at Drexel said, if you make clinical predictions based on somebody's race, you're going to be wrong a good chunk of the time. For example, cystic fibrosis, which is underdiagnosed in people of African ancestry because it is thought of as a white disease. So race is a social construct, but that doesn't mean that it doesn't have impact, because social constructs do impact health. So they access education access and quality, healthcare access and quality, the neighborhoods in which people live and the environments around them, social and community contexts, as well as economic stability. So again, a social construct, but has real impacts on health. So therefore, we really do need to understand them in the US, in the context of the US. So even the US Census Bureau actually says on their website, racial categories included in the census questionnaire generally reflect a social definition of race recognized in this country and are not an attempt to define race biologically, anthropologically, or genetically. Nonetheless, we'll talk about these categories throughout the presentation, so it's important that you understand to what we're referring. So the race categories defined in the United States by the Census Bureau: white, Black or African American, American Indian or Alaska Native, Asian, and Native Hawaiian or other Pacific Islander. There's only one ethnicity category here in the US. So race has been established based on physical characteristics as a social construct, but ethnicity tends to be defined by shared culture, language, ancestry, etc. So the ethnicity category here in the US, Hispanic or Latino, refers to ethnic origins in Spanish-speaking countries or Brazil, which of course is a Portuguese-speaking country. But again, 5 race categories and 1 ethnicity category here in the US. So now let's go on to talk specifically about cystic fibrosis. So as Dr. Collins mentioned this morning, Dr. Dorothy Anderson was the first to describe cystic fibrosis as a clinical entity. And when she gave her first description, she recognized that cystic fibrosis did not just occur in white people. In fact, in her first report, she said there was a case of a Black child with cystic fibrosis, as well as one that was Puerto Rican. And she specifically pointed out that the racial and geographic distribution of cystic fibrosis was wide. However, somewhere in the last 100 years, that message was lost. And most of us have read in many, many articles that cystic fibrosis is the most common lethal genetic disorder in the Caucasian population. And that's absolutely true. But that repeated sentence led people to believe that it only occurs in white people, which of course we now know is not true. Increasingly, over the last 15 to 20 years, reports have appeared in the literature of cystic fibrosis occurring in people from all over the world. And it's important, therefore, that we teach and make sure that people understand that CF can occur in someone of any race. Right now, we estimate that there are approximately 30,000 people with CF here in the US and 80,000 worldwide. But I suspect that that number is even larger. And as we begin to diagnose and evaluate people in these countries that are not only white countries, we'll find that there are more and more people with cystic fibrosis. So again, it's critically important to teach and recognize that CF can occur in someone of any race or ethnicity. So what is the incidence of CF by race and ethnicity here in the United States? So this data is taken from the US CF patient registry in 2019. You can see that 84% of the population in the US is white with CF, 4% represented by the orange color is African American, and 9% is Hispanic of any race. Again, that's considered ethnicity here in the US, and 3% report as other. So I particularly want you to remember that approximately 4.7% of the US CF population is African American, and just over 9% is Hispanic. Those numbers will be important later. So how do we diagnose cystic fibrosis? Well, as of 2010, newborn screening for CF was included in every single state in the US. And so the median age at diagnosis for CF in the US in 2019 was 3 months. And more than 60% of newly diagnosed people with CF were detected by newborn screening. So why do we do newborn screening? Why do we try to diagnose people early? Well, we know that children who receive care early in life have better nutrition status and are healthier than those diagnosed later. And how do we do newborn screening? Well, it actually differs by state, but in every state, the very first test is a measurement of immunoreactive trypsinogen, or IRT, a measure of pancreatic function, and then with or without a DNA test for CFTR mutations. At this point, there are over 2,000 mutations that have been described in the CFTR gene, the most common of which, of course, is F508del. There are only 5 other mutations that occur at a frequency of more than 2%, and that's important. So this table on the right is showing you the prevalence of the 25 most common CFTR mutations in people with CF in the registry in 2019. And what I've highlighted in blue is those mutations that are more commonly seen in people of Hispanic descent, and in red, those in people of African American descent. And you can see that many mutations are not on this table, and those rare mutations occur more frequently in people of color. And that makes a huge difference for diagnosing CF. So commonly used DNA panels that would only use those 25 or 30 mutation panels are really likely to miss rare mutations that are common in Black, Indigenous, and people of color with CF. One recent survey found that over half of State Department of Health websites in the US refer to CF as a Caucasian disease. And if that is their viewpoint, then they're not going to think about including these rare mutations, and therefore people of color will be missed. And in fact, Fisher and colleagues showed that ethnic and/or minority infants had their first CF center evaluation, whether it was a sweat test, a phone encounter, or a care episode, on average 9 days later than non-Hispanic white infants. So from the very start, people of color are being diagnosed later and put at risk for poorer health outcomes. Now, what about adults with CF? We do know that there are going to be people who will have been missed by newborn screening because it didn't exist yet in their state, or they were just missed on newborn screening. But there is a classic presentation for adults. They often present to physicians with more sinus and pulmonary symptoms, and their gastrointestinal involvement is varied. So often they have a functioning pancreas, and sometimes they have recurrent pancreatitis. They often have less common mutations and an indeterminate sweat chloride. Unfortunately, it's very unlikely for CF to be considered in people who are adults presenting with CF who are not white. In fact, Terry Wright has talked about this many times. He was actually told, if you weren't Black, I'd say you have the classic symptoms of CF. And he wasn't diagnosed at that time and continued to suffer signs and symptoms of CF solely because he was Black and his physician did not think that he could have CF for that reason. We must do better. So as Dr. Collins told you this morning, survival really has changed as we've developed more and more therapies for people with CF. And in fact, in 2019, based on the CF patient registry, people's average predicted survival was almost 50 years. But unfortunately, outcomes in people of color are still quite adversely impacted. So for example, Hamish and colleagues used the US CF patient registry in 1994 and found that percent predicted FEV1, our measure of lung health in CF, was 3.9% lower, and weight for height percentile was 6 percentiles lower in Black children with CF than in non-Hispanic white children with CF. That was in 1994. Now fast forward to use of the registry data between 2008 and 2013 by McGarry and colleagues. They found that compared to non-Hispanic white people with CF, Hispanic people with CF acquired Pseudomonas at a younger age and had a higher risk of chronic Pseudomonas, of mucoid Pseudomonas, and multi-drug resistant Pseudomonas, all poor prognostic factors. And then Fisher and colleagues demonstrated that Black race is independently associated with later age at diagnosis, as I mentioned, with newborn screening, and consequently decreased weight for age at 1 year of age. So again, adversely impacting health outcomes. What about survival? Also, unfortunately, lower in people of color. So Macaulay and colleagues used data from a very large study called the Epidemiologic Study of CF, in which data was collected from 1994 to 2005. And they used that in combination with the registry to study risk factors for death before the age of 18 years. Of almost 4,000 people with CF under the age of 18, about 5.7% died before the age of 18. And in addition to the signs and symptoms that you might expect to be associated with a higher risk of death, race, non-white race, was associated with increased risk of death. And in fact, even if you considered lung function at a very early age in childhood, non-white race and/or Hispanic ethnicity was a risk factor for death. Now that's in children, but what about in adults, and specifically in adults with advanced lung disease? Ramos and colleagues studied survival and lung transplant outcomes for people with advanced lung disease living both in the US and in Canada. And what they showed is that people in the US were less likely to receive a lung transplant and more likely to die without a transplant. And we've seen from previous data that often the healthcare system in Canada is protective for people who are living there with CF because they have access to care. But in both Canada and the US, the differences were heightened for people who were non-white. So race that was non-white was associated with less likelihood of receiving transplant and more likelihood of dying without a lung transplant. So I've talked about diagnosis and I've talked about outcomes. What about clinical research? So doctors Megan McGarry and Susan Macaulay asked whether or not race was being reported in clinical trials that are done in people with cystic fibrosis. So they looked at clinical trials and specifically pharmaceutical trials between 1999 and 2015. And of the 147 trials that they found, only 19% actually reported race. So 80% of the trials did not report race. They then went on to look at the 29 trials that actually did report race and looked at the percentage of Black, Indigenous, and people of color with CF that were included in those clinical trials and compared that to the number of people who were actually in the CF patient registry for those years. So you look at the graphs on the right side of the table. On the y-axis is a percentage of people with who were Latino first, who were Black, or who were Asian. And you can see that the numbers of people with CF who are Latino, Black, and Asian were increasing over time in the registry. However, if you look at the percentage of people who were included in clinical trials, those numbers really didn't increase very much and are well below the levels of the population prevalence in each and every single group. So Black, Indigenous, people of color are not being included in clinical research at the rate at which they're seen in the population. And you might think, well, that's older data. It's got to be better now. Unfortunately, that's not the case. So this is a graph showing inclusion of people of color in phase 3 trials of Alex-Tez-Iva, Trikafta here in the US and Kaftrio in Europe and the UK. On the y-axis is a percent of Black, Indigenous, and people of color or white people that were included in the trial. And what you can see is that 95% of the trial participants were white. Only 4.1% were Hispanic compared to, again, approximately 9% of the USCF population being Hispanic, and only 1.2% of trial participants were Black, again, compared to about 4.7% of people in the USCF patient population being Black. So people are being excluded from trials of life-altering treatments during which there are open label opportunities to participate. So around the time of Kalydeco or ivacaftor approval, one of our adults with CF from Colorado had the opportunity to go and speak to the FDA, and he also had the opportunity to meet President Obama. At that time, former President Obama said, "I want the country that eliminated polio and mapped the human genome to lead a new era of medicine, one that delivers the right treatment at the right time." In some patients with cystic fibrosis, this approach has reversed a disease once thought unstoppable. And of course, as Dr. Collins mentioned this morning, we do have 4 approved CFTR modulators in the US right now, with coverage for approximately 90% of people with CF. So ivacaftor or Kalydeco is available for people over the age of 4 months with about 97 mutations. Lumacaftor, ivacaftor, or Orkambi is available for people who have 2 copies of F508del who are over the age of 2. Tezacaftor, ivacaftor, or Symdeko and then Symkevi in Europe and the UK is available for those over age of 6 who have 154 mutations, including homozygosity for F508del. And then Alex-Tez-Iva, again, Trikafta or Kaftrio, is available in the US for those over the age of 6 who have at least 1 copy of F508del and an additional 177 mutations. So in the image on the right, you can see that there are only about 8, perhaps 10% of people who are not eligible for CFTR modulators. But unfortunately, the access to modulators is unequal. So many of you have heard people speak of the final 10%, the 10% of people with CF who do not qualify for CFTR modulators. However, it's really important to consider that when you talk about 10%, that only refers to the population of people with CF who are white. So Shriver and colleagues actually went through and looked at mutations and looked specifically at people who did not have a copy of F508del. So the original approval for Alex-Tez-Iva was for people who had at least 1 copy of F508del. And they looked at the number of people in each population who did not have a copy. And you can see that for the white population of people with CF, that was 10%. But for Hispanic, Black, Asian, and Native American people with CF, that percent who did not have a copy of F508del was much, much higher. Subsequently, Doctors McCauley and McGarry looked specifically at the USCF patient registry and asked, who is eligible for CFTR modulators? And again, you can see that 92% of the white population of people with CF was eligible. But if you look specifically at Hispanic and Black people with CF, they were much less likely to be eligible for approved CFTR modulators. So people who are being diagnosed late, who have poor outcomes because of systemic bias, are also less likely to qualify for these life-altering therapies. So when we think about medical system distrust, we often go first to Tuskegee, which of course was a horrible, horrible medical tragedy that occurred in which people were observed for the natural history of syphilis instead of actually being treated for syphilis. And many men suffered and died because of this. But this isn't the only issue that's happened in the US. So the image on the left is actually an example of a physician who has been revered as the godfather of OBGYN. He perfected a technique to repair something called vesicovaginal fistulas, so fistulas in the bladder to the vagina. But the way he did this was only revealed recently. So essentially, he bought slaves and he used them to conduct these experimental surgeries without their consent and without any anesthesia. Of course, access to healthcare is no longer quite this obvious when it's not being allowed, but for many, many years, access to healthcare and treatments were quite different based on race. There are also many, many examples of people with people who are of color being mistreated in research or not even consented at all. So this more recent example of Henrietta Lacks is that she actually died of cervical cancer, but her cells were obtained without her knowledge or permission and without the knowledge or permission of her family, and then subsequently used by researchers throughout the world to do experiments, create new therapies. Again, medical mistreatment, research mistreatment creates medical system distrust. And that is done over and over again. And there are also just everyday acts of bias, such as Mr. Wright being told that there was no way he could have cystic fibrosis because he was Black, or an example of a mother who had another child with CF and was told that the child that she also thought had CF couldn't possibly have CF as well, and was accused of possibly not feeding her child enough because her child wasn't gaining weight instead of being diagnosed with cystic fibrosis. These acts over and over again create medical trauma. So there's late diagnosis, there's misdiagnosis, there's exclusion from research. All of these things contribute to medical trauma. And there are strong associations between experiences of racism and poor mental and general health. Recently, people have discussed telomeres, which are non-coding repeating sequences of double-stranded DNA at the end of chromosomes. And it's been shown that chronic stress exposure accelerates telomere shortening, which is important because the rate of telomere shortening is critical to an individual's health and the pace at which they age. Recent studies have shown an inverse association between perceived racial discrimination and telomere length. So in other words, every act of discrimination, whether it's in daily life or whether it's in the medical setting, is literally shortening people's lives. At a conference in 1966, Dr. Martin Luther King said, of all the forms of inequality, injustice in healthcare is the most shocking and inhuman. We have to understand that, unfortunately, our system creates that inequality. And because every system is perfectly designed to get the results that it gets, we need to understand that system and we need to change it. Now, I think to get us again all on the same page and really understand the system, it's helpful to watch this video.
Oppression. It's a word that's often used as a blanket term, but there's actually a whole lot more to it. There are 4 interlocking aspects of oppression: ideological, institutional, interpersonal, and internalized. And it might seem like a small difference, but it's very important to be able to distinguish between each kind, because understanding oppression is the first step to fighting it. Let's start with the core at the heart of every form of oppression: ideology. Every system of oppression comes from the idea that one group is somehow better than another. Ideological oppression starts when the dominant group associates positive qualities with itself and negative qualities with the marginalized or othered group. Ideological oppression describes the deeply ingrained social root of inequality. It's the larger overarching idea that leads to the isms. For example, the idea that black people are dangerous is ideological racism. The idea that poor people are lazy is ideological classism. Ideological oppression leads to institutional oppression. Institutional oppression is the way that systems and institutions manifest the dominant ideology. Institutions control access, who is able to get to what and how. This includes legal rights, police practice, access to medical care and education, public policy, political power, and media representation. For example, when women make 2/3 of what men make, that's institutional sexism. When a building is constructed without wheelchair ramps, that's institutional ableism. All of this leads to interpersonal oppression. Interpersonal oppression is probably the easiest to recognize because it happens all around us. Interpersonal oppression is the way that people play out discrimination and violence on each other. It can take the form of microaggressions, jokes, stereotypes, and harassment. For example, when a student is bullied for being gay, it's interpersonal homophobia. When a Muslim person is told that they're a terrorist, it's interpersonal Islamophobia. And all those forces, ideological, institutional, and interpersonal, lead to internalized oppression. Internalized oppression is the way that people with marginalized identities internalize narratives of their own inferiority. It's what leads people to feel less than. This is the end goal of oppression. The oppressive party doesn't need to exert force any longer because the marginalized group is enacting oppression on itself to maintain the status quo. It's important to remember that it's never a marginalized person's fault that they feel internalized oppression. It's simply what happens when someone faces negative stereotypes, low expectations, and ongoing discrimination. So, for example, an immigrant feeling embarrassed about having an accent is internalized xenophobia. When a trans woman feels that they can never be a real woman, that's internalized transphobia. So, to review, the 4 I's of oppression are ideological, institutional, interpersonal, and internalized. Each of these types are interconnected and completely supported by the others. They can never exist on their own and can even be seen as a cycle. Now that you understand the different kinds of oppression, you're even more equipped to fight it. Don't forget that any effort to dismantle oppression should aim to address it at all 4 of these levels. Thanks for watching.
So she talked about the 4 different ways that oppression occurs and addressing all of them. But I think the very first step that we have to do is acknowledgement of the issue. And recently, both the Centers for Disease Control and the American Medical Association, which incidentally actually excluded Black, Indigenous, and people of color from inclusion in their group for many, many years, but both the CDC and the AMA have recognized that racism is a serious public health threat. So if we're ready to acknowledge the problem, what is the next step? So I just remind you of those 4 levels of oppression: ideological, institutional, interpersonal, and internalized. And of course, it's beyond the scope of the CF community to change our entire society, but we each do have a sphere of influence. So let's first focus on internalized oppression. All of us are inundated with images on TV, in the news, from a very, very young age. And I think that this video really shows how oppression is internalized.
In Brown versus Board of Education, the famous case that desegregated schools in the 1950s, Dr. Kenneth Clark conducted a doll test with Black children. He asked them to choose between a black doll and a white doll. In most instances, the majority of the children preferred the white doll. I decided to reconduct this test as Dr. Clark did to see how we've progressed since then. Can you show me the doll that you liked best or that you'd like to play with?
This one. I like that one.
I'm kidding.
This one.
That one?
I like a flavor of this.
I And can you show me the doll that is the nice doll? And why is that the nice doll?
He's white.
And can you show me the doll that looks bad? Okay. And can you give, and why does that look bad?
Because it's black.
And why do you think that's a nice doll?
Because she's white.
And can you give me the doll that looks like you? "15 out of the 21 children preferred the white doll."
So I've seen that many, many times, and it still gets to me every time. So it is a great example of how oppression is internalized. So what can we do at the internalization and interpersonal levels? Every single one of us has bias. As I mentioned, we're inundated with images from the time that we're young children. But we really do need to understand what our own biases are. And again, we're not bad people because we have bias. It's just something that happens based on our society. You can actually go to the website that's linked at the bottom of this slide to go and do the Harvard Implicit Association Test. So what is it? It measures attitudes and beliefs that people may be unwilling or unable to report. It may be especially interesting for you to do this if it shows you an implicit attitude that you did not realize that you had. So for example, you may believe consciously that women and men should be equally associated with science, but your automatic associations could show you that, like many others, you associate men with science more than you associate women with science. And there are numerous examples in the medical literature showing that people of color, the darker their skin, are judged to be bad or poor historians, etc. So everyone has these biases, and in order to combat them, you need to be aware of what they are. So Professor Ibram Kendi, who has written some excellent books, says that being anti-racist requires persistent self-awareness, constant self-criticism, and regular self-examination. So I would urge you to read about US history that includes a BIPOC perspective, which is often not currently taught in our education system. Attend lectures like this one and others. Ask your BIPOC patients and colleagues about their experiences and listen to them without invalidating them. And what do I mean by invalidating? Well, for all of you young people, I mean gaslighting. So if someone comes to you and says, "This happened to me and I feel like it was racially motivated," don't try to explain to them like what a nice person that you know that person is that just made that comment. Listen to them and try to empathize. Also, be an ally or an upstander. Desmond Tutu said, "If you're neutral in situations of injustice, you have chosen the side of the oppressor." So speak up early and often in order to build more inclusive environments. If you see bigotry in the clinic, in the clinical research unit, speak up about it. Workplace culture largely is determined by what is allowed or isn't allowed to occur. So if people are lax in responding to bigotry, then bigotry is going to prevail. We also need to increase awareness. In the general public, we need to do outreach, and many institutions are already doing this. We need to educate the general public that cystic fibrosis can occur, for example, in anyone of any race. And that will allow people with CF who have yet to be diagnosed to advocate for themselves, that they are aware that that exists. We also need to increase awareness and educate care providers, those who already take care of people with CF, primary care physicians and providers, subspecialists. We can do this through conferences, through publications. We need to educate and increase awareness among law and public policymakers. So I already gave you the example of newborn screening. If people are not considering the bias that is created by the historical way in which CF was presented to the reader, they are not going to be conscientious about including the appropriate genetic mutations on their panel, for example. So we need to change those kind of levels of awareness. We need to change access to healthcare and to research funding. We also need to increase workforce diversity. And why do I say that? So while the number of Black, Indigenous, and people of color medical students has increased, the proportion of BIPOC faculty in US medical centers really has changed minimally in the last 20 years. And why does that matter? Well, as I've mentioned already, implicit beliefs have an impact. They can impact interaction with patients through nonverbal behaviors like eye contact, speech errors, and avoidance behaviors that convey dislike or unease, and that adversely impacts the trust relationship with the care provider. And for that reason, BIPOC patients may prefer and have better interactions and health outcomes with physicians from their own background. But if there aren't any physicians of their own background present, that's not even an option that's available. Also, an institution that includes people from given racial or ethnic communities may seem more trustworthy or approachable to members of that community and may increase their likelihood of returning to that institution. Finally, BIPOC medical students express a greater level of commitment to serve the underserved and are more likely than others to fulfill that commitment. We also need to make conscientious efforts to increase research inclusion. So that means ensuring adequate BIPOC representation on committees and approval boards so that diverse patient needs are considered throughout the process. We also need research to explore and better define the appropriateness for use of race as a modifier of outcome measures, for example, for pulmonary function testing or for renal function testing, has been mentioned recently in the news. Why? Because these outcome measures may impact whether a Black, Indigenous, or person of color is included or excluded from a clinical trial. Research teams require training to more effectively engage communities of BIPOC in clinical research so we can increase that representation. We don't want to just include every single person of color in a research protocol and increase their risk over that of others, but we do want to make sure that there is adequate representation. So what are we doing right this moment at the institutional level, for example? So some of you may be aware of the CF Foundation Therapeutics Lab Cell Bank, in which researchers are collecting primary human cells from people with cystic fibrosis and using them to study, for example, genotypes that haven't been studied in the big clinical trials. And why is that important? Well, again, these mutations are rare, and it's already been shown by the FDA that they are willing to take data from primary human cells and make drugs more available to people based on that data. And in fact, in December, there was an expansion of the label of Alex/Tezaiva based on that in vitro data. And as we speak at the CF Foundation Therapeutics Lab, they are currently working on 50 mutations that are more common in Black, Indigenous, and people of color. So this is an example of an institutional policy that's been influenced by increased awareness. Also, the CF Foundation and other institutions like CFRI and Emily's Entourage are really working hard to make sure that therapies are developed for every single person with CF. Dr. Polanini recently talked about mRNA therapy, and Dr. Collins this morning also talked about gene editing and gene transfer. Therapies such as these could be made available if they're developed and are successful for people regardless of their mutations, and therefore regardless of the rareness of their mutations because of their race or ethnicity. So in summary, although CF is more common in people of Caucasian descent, it can occur in someone of any race. Treating the basic CF defect has now become a reality, and viable and highly effective therapy is available for approximately 90% of people with CF. However, Black, Indigenous, and people of color with CF are overrepresented in the group of people who are not eligible for modulators. We really need intentional behavior to ensure equitable diagnosis, treatment access, and inclusion in research. For those not eligible, unresponsive, or intolerant of CFTR modulators that are currently approved, and to find a cure for every single person with CF, continued new drug development with adequate representation of every single person with CF is essential. And with that, I will say thank you for your attention, but particularly thank you to people with CF and their families who have been willing to provide their energy and voices to increasing awareness in spite of the fact that there's often an emotional cost to reliving some of those traumatic events. Also to organizations who are using their sphere of influence to affect change. And with that, I will stop, and I think that I have left enough time for us to have some questions.
Yes, you have. Thank you so much, Dr. Taylor-Cousar. And we do have time for some questions. And with that, here comes Siri.
Okay, thank you so much, Dr. Taylor-Cousar. It's funny, I was going to say, we always say to people, stop sharing your screen, but I wondered if maybe you could put that back up.
Back up, okay.
People want to take a screenshot of those resources because that was kind of a gift to everyone to have that right there. And then we can come back to you.
Okay.
If anybody's interested, now is your time to grab the screenshot. Thank you.
Sure.
Thank you, thank you. Really so powerful, so moving. And, you know, as you said about that, like the video with the children with the dolls, I mean, it makes me tear up just watching it. It is so incredibly heartbreaking. I would say for some people that, you know, this is new news in terms of, you know, racism and disparities in the CF community. It's never too late to be informed. And once you have that information, you know, we have to come to terms, we have to move forward. So I just am so grateful to you for all the messages you had there. So I have some questions of my own, but I'll swing back first to those people who put them in the box. And Isa Stendelburns asked, how many of the people considered other, that classification, are biracial with white Caucasian?
Well, first, hi, Isa. It's great to virtually interact. It's a great question, and I actually don't have that data at the tip of my fingers, although I'm sure that the CF Foundation could probably parse it out. But one caveat with that is that there has been research that's shown that when people self-identify, they're not always correct. So with your immediate family, you probably do know exactly what races people consider themselves, but when they've done things even before 23andMe, they've shown that people will often think that they were certain mixes, and they actually, based on their genetics, were unlikely to be that exact mix.
And I have to say, you mentioned 23andMe. I mean, I think I know maybe one person who had the results come and they were what they thought that they would be, you know, what the family history came to bear. Everybody else has had very disparate backgrounds. I mean, we're talking generations of genetics.
Yeah.
So we had somebody ask, where can we get the video? That was Linda, and I'm assuming with the 4 eyes video. So Linda, if you want to re-put that in the chat to clarify, but as long as you know that, is there a place people can access that?
Yeah, they're both on YouTube, actually. So if you just search in YouTube for Black Doll, White Doll for that video, and for the 4 eyes of oppression, you can find both of them in YouTube.
And you know, just this morning when I welcomed everyone, and I said, we always say there's 31,000 people in the US with CF, and that's 31,000 diagnosed people with CF, and how many cases are missed. And so there's discussion in the box about how can these numbers have stayed flat for all these years, essentially, and with the numbers of CF, and how do you think these numbers will change to be more accurate?
Well, actually, you know, the numbers that stayed flat, and I can definitely share a PDF of my slides, but the numbers that stayed flat were actually the inclusion in research. So the number of people identified in the registry as Black, Hispanic, Asian has been increasing over time. And so I think that is only because people are starting to recognize and realize that people can have CF even if they're not white. So those numbers have actually been increasing. The unfortunate numbers that have stayed flat are inclusion in research.
I mean, I do think it is interesting. I mean, my daughter's 26. I think there was 30,000 people in the US have CF way back then, and those numbers really have not changed much. And yet we're an aging population, and so more cases discovered through newborn screening. So it's always mystified me how that number has stayed.
Oh, well, that's okay. So in terms of that particular number, now I understand what your question was. I was thinking about that slide about research. So no, that's another really good question. But I think that if you look at projections from the CF Foundation, it is actually going to change dramatically over the next 20 years based on the improvements in lung function that we're seeing. So unfortunately, even though the predicted survival is 48 right now, the average age of death is still only around 30. So people were continuing to die young. And now with the approval of these highly effective therapies, we are going to see people living longer and longer. So while the number of children with CF is likely to stay around the same, around 16,000, we have newborn screening now. We have actually pre-genetic or pre-pregnancy counseling. And so that may be impacting the peds numbers. But if you think about the adult numbers, those are actually likely going to close to double over the next 20 years. So we're going to go from 18,000 adults with CF to around 30,000 based on the predictions. So they will actually increase. And I think that will increase even more as we start to identify people in other countries, such as in India, where I suspect there is a lot of CF and we just haven't diagnosed it.
Question, do you have any idea of research or care in other countries, Europe, Australia, and what their Black, Indigenous, people of color population with CF looks like? Do they have the same disparities as the US does?
It's a great question. And yes, there are registries available in CF, in Australia, in Europe, and the UK, and they do unfortunately have some of the same disparities that we have, and in some cases even more so, because for example, if you look at our Native American and Indigenous population, there's one example that I can think of that's painfully clear, and that is the Zuni population in New Mexico, where when I was in New Mexico briefly as the co-director of the program, we had not had somebody from the Zuni Pueblo who lived past the age of 13. So there was a high incidence of CF in that population, but because of their access to care and lack thereof, they were suffering a great deal of morbidity and mortality. And that's it's also true for the Indigenous population I know in Australia.
Linda asks, is there a percent of people that aren't counted because they're not part of an accredited care center?
And Linda, hi, that's a great question. And yes, that's definitely true. So there are some people who actually come to the care center and don't agree to consent to be part of the registry, but there are also people who never come to the CF center and therefore are not counted in those numbers.
You mentioned before just all the different layers in which to raise awareness, and one thing I mean on a bigger level, legislation and policy and funding so that states improve their newborn screening programs. I mean, I think there's this perception of CF, we've got it done because every state has it on the panel, and yet there's such huge discrepancies in quality. So there's like the bigger picture I'd love your input on. And then at the other level, pediatricians, I just see them as such a key piece of the puzzle. And how would you suggest people advocate to raise awareness among pediatricians who are the first line for people who've been missed in newborn screening?
So I think that, well, there are a couple of different ways. So again, I think it's on an onus for us at CF Foundation, at CFRI, at Emily's Entourage to use our influence to get that word out to general practitioners, especially to pediatricians, but I also think to adult general pulmonologists, because I cannot tell you how many people I have diagnosed late over the course of my career here at National Jewish alone, where there were obvious signs and symptoms of CF, particularly in people of color, and they were misdiagnosed for years and years and years. So I think both for pediatricians and for general pulmonologists, we really do need to increase awareness through outreach from our organizations that have influence. But another way that I think that we can do that was my first bullet point, and that was about educating the general public. And I think you all are working on something for patients to use, and we are working on one from the CF Foundation as well. It's actually driven by the rights they are creating this document that shows people what the signs and symptoms are of CF, so people can actually advocate for themselves. I gave you the example of the woman who already had one child with CF, and still was, her diagnosis of her child was questioned. But if we have something that people can take with them to their doctor's office saying, see, I have all these signs and symptoms, please test me for CF. I mean, that's unfortunate that we have to have people advocate for themselves, but it's right now the reality that we do need to educate the public so that they can advocate for themselves with general pediatricians and general pulmonologists.
I actually just did an interview for one of the films, awareness films that we're doing with a mother and a young woman who has CF, they're African-American, and those microaggressions you discussed, just every single appointment, every single hospitalization, you know, she is the exotic bird. Oh, you have, really, are you sure? And shared a story that in another room, there was a new diagnosis of sickle cell, and that person looked very Caucasian. Just as we know, what do you know, really? And
right.
That she said that was, it brought it all like to light of what they deal with all the time, and then what this other family will now deal with for the reverse. So much work to do. I really loved what you said about allies. That everybody, I think this is the issue when you talk about disparities of people having their comfort zone. And I really appreciate everybody has a role in this. So thank you. We all need to just lean in and move this forward.
Yeah, and some people aren't comfortable with speaking up, but if you witness, for example, a microaggression or a macroaggression and you're not comfortable speaking up, sometimes what you could actually do is just go to that person afterwards and say, hey, I saw this happen. I'm really sorry I couldn't speak up, but are you okay? And even that is a step forward.
Yes, absolutely. So let's say, and there was one other question I wanted to ask about. Oh, yes, there was that incredible slide. I think I screenshotted it, where it was like the number of health department. I was going quickly. Health departments that list CF as a Caucasian disease. So,
right, so about half, yes.
And is that information easily accessible? To me, that seems like a wonderful starting point.
Well, I think, you know, I'm assuming the way they gathered that data was by going site to site. So I don't know where, I have to go back and look and see if they actually ever published it. It was given in a talk at the NACFC, but right now you have to, I think, go site to site and look at what is listed on each state's website, because of course it's not federally regulated. And so that's why it varies so much by state.
Well, we are running out of time, but this is the beginning of an ongoing conversation for many people here today. I'm so glad to everybody who came to this session. It's so important that we work together on this. Dr. Taylor-Cousar, you are just a shining light for inspiring people to move this forward. So thank you for sharing your very valuable time.
You're very welcome. Thanks for having me.